Emeritus, Department of Shillatrantra, SDM.
Now, the next is about epilepsy. Now, definition of epilepsy has been being changed like almost every year. Earlier definitions were different. The latest definition, which was proposed by the League Against Epilepsy, International League Against Epilepsy, and International Bureau for Epilepsy in 2005, is it's defined as a brain disorder characterized by an enduring predisposition to generate epileptic seizures and by the neurological, cognitive, psychological, and social consequences of this condition. So, the definition has become somewhat wider, which includes the consequences also, and the basic issue is which produces epileptic seizures. That's what it says, and it affects the memory, it affects the psychological conditions and social consequences. Compared to that, the definition which is mentioned in Ayurveda is very rather to the point and more accurate and easily comprehensible. Smriti, Bhutartha Vijnanam, Apashta Parivarjane. Smriti and the situation or being relevant to the surroundings. These are the two important qualities of the life, and when they are lost or when they are affected, that is considered as a apasmara. Smara word refers to Smriti and Bhutartha Vijnana. Smriti is memory and Bhutartha Vijnana is a being is related to the surroundings, or what we call as a cognition. Bhutartha Vijnana is a cognition. So when the memory and the cognition are affected, that condition is called as the apasmara. This is a definition by Sushruta. Whereas in Charaka, the definition has been somewhat more specific. Smriti, Buddhi, Sattva, Samblava, Bhibatsa Chestam, Avastikam Tamha. A temporary situation where the Smriti and Buddhi are affected and it produces abnormal activities. That condition is called as the apasmara, and which is produced due to tamapravesha, abnormality of the tamasa guna. Now, and these definitions were 5,000 years old. Compared to that, in the Western science, the history, if you go into the history, the definition and the perception about the epilepsy are totally somewhat immature. Like in Hippocrates, the epilepsy is named as a sacred disease and believed to be a result of possession, and it was compared to earthquake, and it was supposed to be produced due to internal and external factors as such. In 1684 only considered as a disease of the brain and nervous system, and then of course gradually there are a lot of evolutions. So we will not go into that part, the history part as such, and of course almost everyone knows like what would be the epilepsy meaning like. Now the epilepsy is one of the major health issue, and World Health Organization has considered this as one of the major issues which is to be a globally attention, which requires global attention, and the key facts which are presented by the WHO related to the epilepsy are quite important, and I have just copied it as such without any changing any of the word. That epilepsy is a chronic non-communicable disease of the brain that affects people of all ages. Around 50 million people worldwide have epilepsy, making it one of the most common neurological diseases globally. Nearly 80% of the people with epilepsy live in low and middle income countries. In the low income countries, the incidence is more. It is estimated that up to 70% of the people living with epilepsy could live seizure free if properly diagnosed and treated. That's another of the important issue. A proper treatment can make them epilepsy free. Then risk of premature death in people with epilepsy is up to 3 times higher than for the general population. Fatal complications can occur either as a direct effect of the epilepsy, like accidents which occur during the attacks, or maybe the effects of the drugs or so on. Then 3/4 of the people with epilepsy living in low income countries do not get the treatment they need. In many parts of the world, people with epilepsy and their families suffer from stigma and discrimination. This is another of the issue. The stigma and discrimination, as well as certain of the specific laws which are regulating the epileptic patients and epilepsy conditions also are one of the issues. Now, as far as the pathology is concerned about the epilepsy, there are a lot of theories like how the epilepsy is produced, and I will not go into all that detail. But one of the most popular theory, and which has more this evidence-based theory, is what we call as a paroxysmal depolarization shift, which occurs in the nerve cells. Commonly in the normal pattern, once the nerve cells get activated, the action potential, that action potential would end up at the refractory period, and unless there is another activity, it doesn't produce another stimulus. Unless there is another stimulus, another action potential doesn't produce. And this is done or regulated by inhibitory and excitatory hormones. There are many enzymes in the nervous system which regulate the inhibit the further activity of the nerve cells if there is unless there is another stimulus. And the excitatory would be always having usually excitatory stimuli would be of lower intensity. Inhibitory responses would be control would be of a higher intensity in the normal situation, and hence once there is an action potential produced due to one stimulus, that produces and that ends up there, and that's what we call as the all or none phenomena in the nerve stimulus. But if due to some imbalance or changes in the inhibitory and excitatory responses, that's mainly controlled by the hormone enzymes. And of course, in the brain, it's the gamma aminobutyric acid, which is a major enzyme. Of course, there are other enzymes too. That if there is an imbalance between these two, if one impulse produces or which results in a sudden fluctuation in the excitatory and inhibitory responses, that produces a continuous activity, and there could be a repeated activity as such, and that can produce the convulsions. And the same can be made out with the EEG. In the EEG, if there is a normal regular spiking model in the EEG is if there is one stimulus, you will have one activity. If there is sequence of stimulus, depending upon the rate of stimulus, you will have continuous activity. Whereas in case of that fast spiking model, where the inhibitory controls are reduced, the whole EEG waves would be showing multiple waves. One stimulus may produce a multiple wave as such. Now, another important aspect of the epilepsy pathology is the epileptiform encephalopathies. Like if there is a epilepsy, that can result in a group of syndromes. It's not a single disease, it can produce a group of syndromes where the structure and function of the brain can be affected, and it results in a continuous behavioral changes, behavioral impairments, or cognitive impairment. Cognitive is perception impairment, and it also can produce some changes in the cortex, or it could be the other way. The changes in the cortex can result in the epileptic activity, and such conditions where there is a structural pathology of the brain either produced as a result of the epilepsy or the structural pathology of the brain which produces the epilepsy, they are named as epileptiform encephalopathies. So that's the other theory there. The common causes for the epilepsy are which can be seen in majority of the patients would be from the congenital or genetic early age of life, brain damage, or perinatal abnormalities in the newborn, either loss of oxygen during the birth or low birth weight, etc. Congenital abnormalities or genetic conditions in the brain malformations, head injury, it can be any time, any phase of the life. A stroke, particularly that stroke either as a result of the stroke, the oxygen to the brain is reduced, or a stroke which can produce a fibrotic changes, or maybe a structural pathology like sclerosis, or maybe a blood clot, and so on, which can act as a needles or focus there, or infection of the brain such as meningitis encephalitis. Meningitis we have already refer to, and encephalitis also. And certain genetic syndromes, genes also now are identified, which make the person predisposed to the epilepsy, and that can be the other causes. Or brain tumors also can present as epilepsy. The epilepsy conditions are classified under different approaches. The one of the simple classification is based upon the location of the lesion, whether the lesion can be identified or not. And related to that, localization of the epilepsy, it's categorized as focal or partial. Focal is when a part of the brain is affected, and that's also called as partial. Or generalized is when whole surface of the brain is affected during the attack, or the abnormal nerve activity is seen in some part of the brain, that's called as focal or partial. When the abnormal activity is seen throughout the surface of the brain or throughout the cortex, that's called generalized. And of course, the earlier the generalized epilepsies were named as grand mal epilepsies. The names are now changing. Then there is a idiopathic epilepsy, where the exact pathology is not seen or cannot be seen as. Then the symptomatic epilepsies are those which are known to produce due to some brain disease like a scar or a infarction in the brain, or maybe a tumor in the brain, and so on, which could produce that. Then epilepsy syndromes, which may begin as per the age wise, as we have discussed earlier, like congenital or so on. Then based upon the pathology, as I said, depending upon the location of the lesion, the most common classification is a focal onset epilepsy, where there is some area of the brain is involved; generalized onset epilepsy, where the whole of the brain surface would be involved; and combined generalized and focal, where there would be both these aspects, the focal as well as generalized. Then there is an unknown onset. The other and a very long-lasting classification, which was there in the earlier period also, is depending upon the clinical presentation. When the patient presents with the absence seizures, now different types of the seizures we have discussed in the beginning, like what is meant by absence seizures, what is meant by tonic and clonic seizures, and so on. So absence seizures is one type of the lesion or classification. In the earlier classification, it was named as petit mal epilepsy, but these days these words are not regularly used, and the absence seizures word has become more popular. Doesn't make any difference, but somehow I don't know the reason for that. In all the current neurological texts, the petit mal epilepsy word is almost not used, as absence seizures are the words which are used. Whereas the grand mal epilepsy was the older word for generalized seizures. Now the current word is tonic and clonic seizures. Then partial clonic seizures are motor epilepsy. Earlier it was named as motor epilepsy. Now the current term is partial or clonic seizures, or that's also called as Jacksonian motor epilepsy in the earlier textbooks. Now somehow, I don't know the reason for that, but majority of the textbooks now would depend upon the words like absence seizures, the tonic clonic seizures, or partial clonic seizures than really the petit mal, grand mal, and the motor epilepsy, whereas earlier textbooks would classify the same with these names. Now, when you deal with the patient of epilepsy, it's important that you have to rule out the other conditions which can mimic the seizures, which can mimic the epilepsy, but may not be really the epilepsy, or any conditions can produce a syncope, like breath holding spells, cardiac dizziness. Sleep disorders can often produce some activity which resembles that of the different type of the epilepsy. Psychological causes like hallucinations, these attention disorders, panic attacks also can present with similar hysteria, another of the conditions. Autonomic conditions which can present with the meiosis, mydriosis, or so on. Then migraines often can mimic the attacks of epilepsy. Occasionally it may produce confusion, and paroxysmal disorders of movement like spasmus mutans or dystonia or dyskinesia, due to other causes, there could be some confusion with the epilepsy, and hence whenever a patient has an attack of seizure, it's quite important to examine the patient thoroughly or take the history correctly and then make the diagnosis. Now we go into the individual type of the seizures. The absent seizures or petit mal epilepsy again is subclassified into four categories: typical absence, atypical absence, myoclonic absence, or eyelid myoclonia. A typical absence is a condition where the patient has not lost the consciousness, but temporarily he will be just totally unrelated to the surroundings. The eyes kept open, and as he continues to talk or something, all of a sudden there is a pause, and that pause is not known by him. Atypical absence is where the patient may have some activity during that phase, and that activity is not really understood, like repetition of the word. A patient may just be continuously speaking, but all of a sudden, instead of having a relevant continuation of the speech, he may continue to repeat the same words cyclical type. That's atypical absence. Myoclonic absence is there will be sudden movements of any part of the body, but patient is not losing the consciousness. So important is in the absent seizures or petit mal epilepsy, patient would not have the loss of consciousness. Eyelid myoclonia is where there would be flickering of the eyelids as such. And in a number of patients, there will be family history is seen in case of 15 to 40% of the cases. And as per the study pathology, GABA, that's gamma aminobutyric acid inhibition, is the major cause for these epilepsy conditions, petit mal epilepsy conditions, and it's almost now proved. And the usual history is like there would be spells of staring, all of a sudden the patient would be just looking blank at someone, or there could be some behavioral changes. It can result in intellectual retardation, or that's the one. Now, if you have a patient who is suspected to be having petit mal epilepsy, you may trigger that petit mal attack by hyperventilation. Ask the patient to breathe in and breathe out very rapidly for 3 to 5 minutes. It can trigger a seizure. So very often, earlier, of course, now it's not a standard protocol. Earlier, this was one of the protocol of examination. Ask the patient to breathe faster, deeper for a considerable time, and look at the condition. If there is a triggering the attack, that confirms the petit mal epilepsy. So hyperventilation is one of the earlier tests. Now it's not considered as a test now. And a good number of patients of petit mal epilepsy may result in a grand mal epilepsy later. So it's not that the petit mal and grand mal epilepsy are two absolute different compartments, but the approach to the treatment in the petit mal stage is different from the grand mal epilepsy. Typical EEG in the petit mal or absent seizures is like there will be 3 Hz spike, a spike in low intensity, and the continuous wave discharges are seen in the EEG. Now, the EEG changes in the other type of epilepsy also, we will refer to that. Then the treatment for the these petit mal or absent seizures, ethosuximide is the standard drug, and it should not be given in the age below 3 years. Safety and efficacy is not yet established, but if necessary, it can be given at a low dose, and the dosage should be limited. The age, if the patient's age is 3 to 6 years, 250 mg oral per day initially, and the maintenance dose of 20 mg per kilogram per day as such. For in adults, 500 mg oral per day, and in generally should not exceed 1.5 grams per day. Then the other drug, a newer drug which is now becoming more popular, is the valproic acid, and before 10 years the safety is not confirmed, and the dosage is 10 to 15 mg per kilogram dose, and maximum dose should be 60 mg per kilogram per day. And quite important is it can affect the liver function, and hence the patient's liver function test has to be monitored, and hemogram also has to be done. As well as our Ayurvedic prescriptions are concerned, Sarasvarishta and Kamaduga helps a lot. In majority of the patients, it produces a significant change in the total outlook of the condition, unless there is a triggering of the grand mal or tonic and clonic convulsions. Petit mal epilepsy can be effectively managed with the Sarasvarishta and Kamaduga given for 3 to 4 months usually. Then the next is the grand mal epilepsy or generalized tonic and clonic seizures. Generalized epilepsy is produced supposed to be due to three different mechanisms. One is the abnormal response of hyperexcitable cortex to initially normal thalamic input. See, when in the cortex, when the psychological activity or intellectual activity are generated, it's generated based upon the input from the thalamus. The thalamus integrates the stimuli which we see or which we feel around, and that message is reached to the cortex. The cortex plans or activates the relevant muscles or relevant areas of the brain which can produce an activity, meaningful response to the stimuli. But in case of the tonic and clonic seizures, if there is a abnormality suggested or a abnormal response of the cortex supposed to be like, or there could be a subcortical trigger below the cortex, there could be some area where some abnormal nerve activity is produced or seen, like a infarct or so on, infarct or a tumor or so on. That could be the other causes, or there could be the abnormality of the cortical innervation. Nerve structures in the brain cortex could be affected as such, which could be like post-operative surgery, head injury and so on. Then a genetic factor also is identified. Now a specific gene also is now identified, and the details about that also are now available. Then symptoms as well as the grand mal or the tonic and clonic convulsions are concerned. Typically all tonic-clonic convulsions or epilepsy is presented with the prodromal symptom, and that prodromal symptom is called as aura. So in a earlier when we used to read, grand mal epilepsy is always characterized by an aura. Aura is before the attack occurs, the patient would feel something, patient would know that the patient is going to have the attack, and that could be of different varieties, like either there could be mood changes, all of a sudden the patient may feel depressed or so on, or there could be sleep disturbances, patient may feel lightheadedness or some anxiety or irritability, patient may feel that he is having some difficulty in concentrating, or there could be ecstatic feeling, a feeling of joy, and it may be temporary, lasting for a short duration, usually few minutes, or at times it could be few hours also, before the patient develops an attack. Then the next stage is the tonic phase, and this usually lasts for 10 to 20 seconds. During this stage, the patient would be having a sudden spasm of the muscles, myoclonic jerks would occur, and at the same time the patient also would be losing the consciousness. The two important characters of the tonic phase is there will be a sudden spasm of the muscles, and because of the spasm of the muscles, the flexion of the trunk would occur, body would be bending, and the elbows will be also abducted. That's the typical presentation. Usually when a patient lies down during that attack tonic phase, that would be the appearance, and the patient loses the consciousness. Along with that, there would be a possibility of autonomic signs. Majority of them would be having the autonomic signs. There could be increased pulse rate and blood pressure, profuse sweating, and secretions from the respiratory tract also occur. Though urinary bladder pressure raises, voiding does not occur during this stage because of the spasm of the sphincter muscles. Patient will not micturate, but micturation may occur at the end of the clonic phase. Now the next phase is the clonic phase, where the patient it gives to clonic convulsive movements, repeated movements would occur. So that's the typical presentation. Patient may have aura, then there is a tonic phase where the muscles remain contracted and the patient falls in a specific position. Then there would be repeated movements, and in these conditions there would be repeated jerky movements of the body, and it may is at a rapid rate of 4 to 8 hertz also, and there will be a stage where the muscles will lose the tone, atonic state, and then again there is a spasm, and each spasm can also be accompanied by pupillary contraction and dilatation. If you look at the pupils, there will be sudden rapid contractions and dilatation, and during this phase the patient may bite their tongue or cheek, tongue may fall back and produce an obstruction of the respiratory tract. That's one of the major critical issue in a patient with the clonic phase. The tongue may fall back and block the respiratory tract and can be one of the causes for a sudden death. And then there will be a gradual increase in the atonic phase. See, the attacks will be very classical. Initially, there would be a sudden spasm and a short duration of the relaxation. Then again another spasm, then another duration of relaxation. During each attack, like during each of these spasms, the duration of atonic phase or duration of the relaxation gradually increases, and at one stage the spasms would end and it's only the atonic phase may remain. And during this atonic phase, the patient may micturate because of the loss of sphincter muscle or sphincter muscle tone. And most of the times when the patient micturates involuntarily, that may be considered as the end of the clonic phase, but it's not a standard criteria. And usually this atonic period lasts for 30 seconds. Then there could be apnea during this patient may not breathe properly, and that's one of the things which you have to observe. If the patient may not be breathing at that time, you have to consider whether the patient may require a respiratory support or not. Most of the times it is not required, but if you have to keep the air passages patent so that the patient would have some amount of oxygenation available. Then there is a post-ictal state after the attack. Ictal is an attack, and after the attack the stage would be includes usually impaired consciousness. The patient would regain the consciousness, but the consciousness may not be perfectly normal. It may not reach the baseline, but patient may have some impairment of the consciousness, and then the patient becomes quiet and breathing also resumes. So that's once the patient starts breathing, then we can assure that the patient has reached the post-ictal state, and then there is no immediate danger of life-threatening complications. Then gradually the patient awakens, or maybe he may go into a sleep, and slightly temporarily he may have been confused, and maybe some automatic behavior like moving here and there or so on can also occur. It also may be followed by headache and muscular pain, which is quite common. And most of the times the patient doesn't remember, like he had a seizure, he doesn't recall the seizure. That's the typical presentation of tonic-clonic seizures. The most important complications which can occur during the tonic-clonic phase of a seizure would be injury, which can be inflicted during the attack. Most commonly it is the head injury or tongue bite, lips, cheeks. And another important issue is the respiratory blockade which can be produced due to the tongue falling back, or aspiration, because the patients would have a lot of secretions and the saline reflexes are not affected, the same may get aspirated. There could be compression fractures of the vertebral body. There could be a pulmonary edema produced due to the same because of the persistent apnea for a long time. Cardiac arrhythmias can occur. Sudden death also can occur during these phases of tonic-clonic conditions. That's about the clinical presentation of tonic and clonic epilepsy or grand mal epilepsy. The focal motor epilepsy or Jacksonian motor epilepsy is presented with a typical sustained contraction or posturing of the limb with the typical movements. The patient may have a movement of some parts of the body with the contractions, or there could be clonic movements, the jerky movements of some part of the body. But characteristically in a motor epilepsy, patient would not lose the consciousness, but involuntary movements would occur temporarily. Either there could be a sudden spasm of the muscles at some area, or there could be clonic movements, or there could be atonic movements, sudden loss of the tone and the limb may become flaccid. So either it's a sudden spasm or repeated clonic movements, or it could be a impaired tone or flaccidity of the group of muscles which can produce a area of the body being relaxed, or sudden reduced strength in some areas of the body. And they are usually characterized by irregular, non-rhythmic, non-repeated jerky movements of the body. Repeated movements of the body which occur literally are called as a chorea, whereas the Jacksonian would be non-repeating, non-rhythmic. There would not be any specific rhythm also. or it can also presented like hyperkinetic movements. It looks like the patient is doing the activity more rapidly than earlier. That could be the observation many times. Or it can be presented with the flexion of the waist and flexion of, and extension of the arms, which may make the patient's body bend, which may, it's not limited to some part, limb only. When the core part of the body is involved, the patient may have a repeated flexion of the weight, that flexion and extension of the core part of the body, chest also, and it may look like some dancing movements. Or automatisms may occur at times, like tapping, swallowing, chewing, etc. The patient may look like having certain specific normal movements, but which is uncoordinated, which is not coordinated, which is not really under the control. That there could be movements like chewing, tapping, swallowing, etc. The focal non-motor epilepsy again can be a presentation where there could be autonomic seizures than really what we see in the exterior. Autonomic seizures, like there could be a sudden change in the blood pressure, heart rate, sweating, skin or gastrointestinal upset like nausea, vomiting, or there could be behavioral arrest seizures where there could be a sudden cessation of the movement. Patient would be conscious, but the patient would not be able to move, patient would not be able to do the normal activities, but all of a sudden he becomes silent. Or there could be a cognitive seizures. Temporarily the patient would not be able to speak. She loses that capacity to speak temporarily for a moment, and he may be related, he may not be related to the surroundings. Jamais vu or deja vu. We have discussed these issues words earlier in the beginning of these seizures classes, like what described the whole issue. The description of what I mean by the jamais vu and deja vu. And hallucinations and visualizations also can occur at times, and this is called as focal non-motor epilepsy. Emotional seizures are characterized by emotional changes as fear or anxiety or pleasure. At times it could present with these symptoms. And sensory seizures also can occur where the patient may have a sensation, abnormal sensation, and these also could be the presentation of epilepsy. But comparatively, these are less common phenomena. Autonomic seizures with the raise in the blood pressure. Now at present we have that patient in 100, that Ratnashri 121, the male patient with the Parkinson like. She had that episode, and then we had withdrawn that Emantel drug. Now we have restarted the Emantel. Now that's he had that episodes of change in the blood pressure, heart rate, and so on. Now the EEG findings, common EEG findings in typical epilepsy, grand mal epilepsy or tonic motor epilepsy is either there will be synchronous 3 Hz spike. I will show you the images like what we mean by that. Or it could be fast spike and wave activity, or there could be poly spikes. 3 Hz wave which is characterized seen in general epilepsy, tonic and clonic epilepsy, as well as in the absent seizures, would be seen as the waves, sharp waves which are presented uniformly in all the leads. Then a fast spike activity which is typical of tonic and clonic convulsions would be seen as a transient sudden rapid waves at either again in all the leads, which is the characteristic presentation in the EEG. Then polyspikes and slow wave complexes often seen in motor, where you will have irregular sized spikes seen at areas, and the size of these spikes are not uniform in all the leads. That's what we see in case of the motor epilepsy or Jacksonian epilepsy. Then if at all you get a EEG during the attack, ictal EEG, there will be during the tonic phase of the condition, there will be a progressively higher amplitude. The amplitude of the waves will be gradually increasing, and it can reach up to 10 Hz as such, as you see in this lower lead. That will be increased during the attack. Of course, chances of getting a EEG during the attack is less common, whereas post-ictal, that's during that phase when the patient will be relaxed, like there will be a flexibility, then it may show diffuse, low amplitude and slow activity. The total amplitude will be lesser, and it's always corrected related to the hyperpolarization, same issue which we have discussed earlier. At that time the total brain activity would be lesser, and that's how it could be seen. Of course, then other abnormalities which could be seen are either epileptiform discharges, focal slowing, or diffuse background slowing, or intermittent diffuse intermixed slowing as such. Of course, these issues we may not be able to give the samples now as such, but that could be seen. Now, those, what I mean by that is epileptiform discharges are during the resting condition. If you make the patient just somehow activated, there will be sudden that is when the EEG is being recorded. If the patient is awakened or given some stimulus, there will be a sudden discharges at that area, and by identifying that specific area depending upon the lead, it can be made out that epileptiform discharges where there will be sudden episodes of spikes produced. Either or there could be a focal slowing, that the whole wave may become slowed down at some areas. That's what you see in case of the focal slowing. Or diffuse background slowing also could be the other presentation, where there could be a gradual progressive slowing down for a quite a long period. The waves may be slowed down for a long period. That also could be the EEG findings in case of the epilepsy. Or intermittent diffuse and intermittent slow as intermittent faster activity. There could be a slower and less organized delta activity in some leads, whereas in some other leads there could be increased alpha activity. That kind of a variability also could be a sign of underlying epilepsy pathology. So EEG findings are of different variety. The imaging studies in EEG or in epilepsy are not very accurate, or they are not very useful. So EEG is the standard benchmark diagnostic criteria for epilepsy, but some of the conditions can be seen in the imaging studies like CT and MRI. CT and MRI also can be useful in making the diagnosis in only a few of the persons. A negative CT or MRI doesn't rule out the epilepsy. But positive signs which could be seen in the imaging studies are either there could be a atrophy of the hippocampus area of the brain, or there could be sclerosis at the area. Either there could be a hippocampal atrophy, or there could be a hippocampal sclerosis as seen, or there could be cortical dysplasia, abnormality of the cortex, again which could be of two types. Type 1, where there could be some areas, a short area of the cortex is reduced, but the cortical folds are not reduced, whereas in the type 2 is the cortical folds, the number of cortical folds, gyri and sulci are lesser, gyri become wider. This also could be seen, and that's called as type 2 for dysplasia, cortical dysplasia condition. Or there could be a encephalocele, that there could be some areas where there could be a fluid accumulated, or there could be a bulging of some areas of the brain tissue as you see over that. There could be a projection of the brain tissue beyond the normal area over the pons area. That could be the other signs which could be a cause for the epilepsy. Or focal cortical dysplasia, some areas of the cortex present with the dysplasia as well as some sclerotic areas. This also could be the sign of epilepsy. Or there could be a nodular heterotopia, some areas of the brain tissue, the nerve tissues are of abnormal consistency. The density of the myelin sheaths would be altered, and that can be presented as the signs of epilepsy in the CT or MRI. But currently, the latest in the diagnosis of epilepsy, PET scan is considered to be a benchmark. PET scan can show the brain activity, metabolic activity also, and many of the epileptic foci which may not be seen in CT or MRI, or even many times missed in the EEG, can be made out with the PET scan, where it can be seen as area of increased metabolic activity. That green, dark green suggests about the increased metabolic activity in the area, as that could be the signs. So diagnosis of epilepsy requires all that issues. Now coming to the treatment. Now your approach to the treatment will be depending upon the stage which the patient is seen. Suppose the patient is brought in a stage of convulsions, then the approach would be, the first approach would be, because you will not know the real cause for the condition, the patient may be brought in the stage of convulsions, or you may be called during the convulsions, and you do not know the history, like whether the patient really had a history of epilepsy or not. The first of the approach would be, you have to confirm that the patient is kept alive. So any patient who is brought in unconscious or a convulsive seizure stage, the airway and breathing and circulation, they have to be maintained. So that's one of the important issue. And a proper recording of the time of seizure onset and the evident signs, vital signs have to be recorded. Ensure that the patient gets sufficient oxygen, either with a mask or a cannula, or if necessary intubation, and ECG has to be monitored, and maybe the blood test like sugar, because one of the common causes for the seizure or unconsciousness would be hypoglycemia, so that has to be treated, and you get a IV line open. Now if you are sure that it is a seizure, epileptic seizure, then the first of the thing would be benzodiazepines, would be the usual treatment. Diazepam is the usual treatment. So all that you can do is in the first 5 minutes stabilize the patient and maybe guess about the possible causes of the unconsciousness. And as far as the clinical incidence is concerned, the most common cause is the blood sugar hypoglycemia being the cause for the unconsciousness, or the sodium hyponatremia is the other cause. These have to be possibly identified within that 0 to 5 minutes time. Then the standard protocol is you have to finish up this job and confirm like whether the patient is having a real seizure or epileptic seizure or not. And then the epileptic seizures, the drug of choice for the first episode or during the episode is benzodiazepine. Diazepam is the drug of choice, and either it could be given intravenous or the other choices. If you are not giving diazepam, it could be metazolam or iprazolam or diazepam. As I told you, diazepam is the best drug, and diazepam dose is 0.15 to 0.2 milligram per kilogram per dose, and if needed you may repeat the dose as such. And or if the patient doesn't respond, or if you have a facility for intubation, then you may prefer intravenous phenobarbital also, that's a injection, or in children rectal diazepam also could be used. Now if the patient recovers fine, then you will have to follow the usual treatment for the epilepsy. That's during the attack. If the patient recovers, that is one. If the patient doesn't respond to your diazepam treatment, then the other drugs could be the specific anti-epileptic drug. So when a patient presents with the active convulsion, it is the benzodiazepines which are the drug of choice. But if the patient doesn't respond and if the seizures continue as such, then a specific anti-epileptic drug like either phenytoin or valproic acid or levetiracetam could be used as such in the treatment. That's how the protocol is done, and this should be done within 20 to 40 minutes. Now if the patient recovers fine, if the patient doesn't recover, then you will have to have the treatment like thiopentol, or patient has to be anesthetized, intubation has to be made, and the patient has to be maintained on breathing with the intubation. Closed ventilation is required, and acute emergency care is required. Only when there is a sign of recovery, intubation can be removed. As far as the anti-epileptic drugs are concerned, the oldest of the drug is bromides, and still they are being used. And now you have second generation and third generation drugs. In the second generation drugs, levetiracetam is now becoming popular, whereas the other 1981 valproate is another popular drug which is used, and clonazepam is another of the drug which is now popular now. These are the popular drugs. Ethosuximide is specific for petit mal epilepsy or absence seizures, and now the third generation drugs now are being identified, and this is the esclarcarbazine is considered to be the latest. Now, as far as the mechanism of action of the commonly used drugs now would be phenytoin, it blocks the repetitive action of the sodium channel, and drugs which do that kind of an activity are carbamazepine, oxcarbazepine, and lamotrigine also. They block the sodium channel. Now, the purpose of referring to this issue is that the drugs act through different mechanisms. Different drugs act through different mechanisms. When a patient of epilepsy comes in, it may not be possible to know exactly which is the mechanism affected in that person. So most of the time the selection of the drug would be by trial and error. So if the one drug doesn't produce the effect, then you will have to go for the other drug which will have a different site of the action. Now, among the conditions which are presented as epilepsy, the most common cause for the epilepsy is abnormality of the sodium channel activity or GABA activity. And phenobarbital, benzodiazepines, they would be more specific on the GABA activity conditions. Phenytoin, carbamazepine are more active over the sodium channel blockers. Whereas valproate is considered to be a broad spectrum drug, though the specific activity is on calcium channel activity. It's considered to be a broad spectrum drug. Phenytoin is now considered as a broad spectrum drug. Broad spectrum in the sense, even if the patient has any of the other pathologies, so it can be used. Or if at all you have the facility to go for the specific investigations and identify the exact type of the pathology, which is virtually not possible in almost every centers in our vicinity. Only in a very high advanced centers you may have that kind of investigation facility where the exact type of the pathology in a patient of epilepsy can be made out and a specific drug can be selected. Otherwise, most of the times it's a trial and error, or if one drug doesn't help, you give another drug. Multi-drug therapy is the usual practice. But from the theory point of view, if at all you have that facility, if you know exactly the type of the pathology, the drug could be selected specifically. That's one. Then whenever a patient has an epilepsy and you start with the anti-epileptic drug, generally if the patient has no seizures, typically for 2 to 5 years, medicines may be gradually tapered and discontinued. Even after the discontinuation, relapse rate of seizures in adults is around 40 to 50%, whereas children it's around 25%. About 70% of the seizures relapses after medication discontinuation after 1 year, or some 50% of the patients within 3 months as such. So, the chances of recurrence or the repetition of the seizures is higher after a year or so. Now, as far as Ayurvedic medicines are concerned, if a patient comes with an anti-epileptic drug online, I would not stop that. I would continue along with that, and then we will Smithsagarasa, Kamaduka, Sarasvarishta. Tailadhara and Matrabasi is the other option. But if the patient comes without any earlier prescription, I would straightforward start with this treatment, and a good number of patients we can control the episodes, or we can maintain. If the patient continues to have the episodes of convulsions, then the anti-epileptic drugs are needed. And this treatment, Smithsagara, Kamaduka, Sarasvarishta, also helps in a early withdrawal of the other drugs. And even if you withdraw the drugs, there may not be any serious complications which can occur. Now, as far as the other options of the treatment, if the medicines do not help, then at present there are 2 other options. Implantable neurostimulator also is now being used in very sophisticated centers, where a stimulator is implanted into the body so that the activity can be suppressed. Or surgical treatment of lobectomy or removal of the lesion also is practiced, but the success rate is lesser, and very few centers are there where these facilities are available. The other these advices in patients of epilepsy is a ketogenic diet. Ketogenic diet is where instead of getting the energy from carbohydrates, you get the energy from proteins or the fat substances. That's one of the issue which has been considered as a standard advice in patients of epilepsy, which can help in reducing the possibility of the seizures. Then another is Valsalva's maneuver or vagal nerve stimulation is another of the accepted tool, which is approved as a tool to reduce the possibility of seizures, or when a patient has a feeling like he is going to have the seizures. Vagal nerve stimulation by massaging the vagus nerve is a standard practice which can help in preventing the seizures. And vagus nerve stimulations are done as per the Western side, exercises, meditation, and cool water, so on. As far as the practical issue is concerned, pranayama is the best means of vagal stimulation, and regular pranayama is one of the recommendations in all patients of epilepsy, which can reduce the possibility of attacks further. Then any patient of epilepsy, you have to take care that the patient, because during the attacks, where the attacks may occur unpredictable, to avoid the risk to the life, these are restricted: the driving, ascending heights, working with fire or cooking, using power tools like or some other rigorously moving instruments, unsupervised baths, swimming. These should be avoided in patients of epilepsy to avoid a sudden complications or fatal complications which can occur. Then a epilepsy patient may develop into a status epilepticus or a super refractory status epilepticus. Definition of status epilepticus is continuous seizures lasting for more than 30 minutes, a tonic and clonic seizures persisting for more than 30 minutes, or any other sort of the seizures, absence or maybe the motor seizures persisting for more than 30 minutes, or 2 or more seizures with the full recovery, without full recovery of the consciousness between any of them within 30 minutes, also is considered as a status epilepticus. Then currently there is another modification. Any seizure that lasts for more than 5 minutes probably needs to be treated as a status epilepticus. Currently this is another of the recommendation, but as per the standard neurology practice, 30 minutes is the criteria. There is a tendency now to reduce that duration to 5 minutes now. As again, it's an issue of controversy, lot of debates and lots of confusion does exist about that part. So maybe in future, in the next episode of our revision of the neurological guidelines, 5 minutes may be considered as a standard guideline. So that's why I have referred to that issue. Then super refractory status epilepticus is defined as a status epilepticus that continues to recur within 24 hours or more after the onset of anesthetic therapy. Even after the anesthesia therapy, if there is a recurrence within 24 hours, or a status epilepticus which occurs on withdrawal of the anesthesia. Causes for the status epilepticus could be exacerbation of pre-existing seizure disorder. A patient who has a previous episode, the epilepsy sudden, that could be exacerbation. Or it could be, many times it could be presented as the first episode of the seizure itself. Most of the times you will have some history, and it could be like patient may have a persistent status epilepticus in the beginning itself, and that condition is named as Epilepsy, not epilepsy. Epilepsy is the word used, rarely used word, but that's the word used for a status epilepticus occurring as the first event in the patient's disease process. It could be as a consequence of the cerebral injury. It could be a systemic disease like uremia, which can be a cause for the status epilepticus. One of the important things is in the patients with the known epilepsy, the most common cause status epilepticus is change in the medication, sudden change in the medications. A status epilepticus is again classified by a Treatment classification as generalized convulsive status epilepticus, subtle status epilepticus, non-convulsive status epilepticus like absence or complex epilepticus. They are simple partial status epilepticus based upon the same clinical presentation issue. The treatment in the status epilepticus would be again the same: benzodiazepines, anticonvulsants, barbiturates, or anesthetics. The same line of treatment. They ensure that the patient's life is vital functions are maintained. So that's about the epilepsy issue. Then supportive care in the patients of status epilepticus would be, you have to ensure that the vital signs are maintained, airway, respiratory support may be required, and you have to have neurological assessment repeatedly and confirm like whether the patient is able to breathe independently, or whether this extra supportive intensive care can be withdrawn or not, which is a very complex issue, and status epilepticus needs an intensive care as such. Now, certain of the other issues related to the epilepsy, one epilepsy and pregnancy, one of the issue of concern. Now, whether a epilepsy patient can conceive or not, whether she can carry the pregnancy or not, it's another issue of the controversy. Now, a few of the anti-epileptic drugs, they may have a teratogenic effect. So, and that teratogenic effect is one of the major risks with the anti-epileptic drugs. Another of the risks with many of the anti-epileptic drugs would be the anti-epileptic drugs would be mobilizing the liver enzymes, and hence they tend to get metabolized rapidly, and hence the blood level could be altered. And if the patient is going to conceive, the blood level of these anti-epileptic drugs has to be monitored and maintained at an optimum level. Now, that's the guidelines for the pregnancy. Universal guidelines are the patient should be educated about the possible complications can occur. If the anti-epileptic drugs are absolutely necessary, it should be depending upon a single drug than multiple drugs. Multiple drugs produce more complications than the single drug. If the change in the these anticonvulsive drugs are needed, it should be done before pregnancy, before the patient conceives. So that should be done. Then a woman taking planning for pregnancy should take folic acid before and during and the early stages of the pregnancy, because it is now known that it reduces the chances of the teratogenicity significantly. Then the patient should also receive vitamin K during the last period of pregnancy. Risks are estimated mortality rate among the women with epilepsy for the entire pregnancy and 42 days after delivery is approximately 10 times higher than the general population. Risk of an epileptic woman dying during pregnancy is around 2 to 3 times higher than during the other period of in her life. This is based upon the global statistics. Source is there. Now, another of the issue, last part, is in India again there are certain laws related to the epilepsy, and the Indian Epilepsy Association has released a booklet on epilepsy and law. Of course, the laws related to epilepsy related to other aspects of the life even. So, if at all you want to go into, you may go through that book. But certain of the important issues which are related to the medical profession and medical handling of the epilepsy is up to 1999, the epilepsy was considered to be a valid reason for nullifying the marriage or divorce. But after that, the law, there is a specific amendment of the law, and this is not a valid reason. So, epilepsy is not a valid reason for nullifying the law, and the marriage can remain valid. But still, many people do not know about it. Still, many people consider epilepsy as a sufficient reason for the divorce, and that is not valid under the law. So, if at all a medical person has to give a certificate like a patient is epileptic, and maybe at times you may have to give some evidences like that, this should be known. Then certain of the other issues, certain major important issues, some amendments in the law. In June 2013, a amendment is done like epileptic students can be exempted from studying third language, and another is medical treatment of specified ailments under section this epilepsy comes under section 80TDB of Income Tax Act. There will be an exemption to the cost of treating epilepsy in the income tax as such. And driving license cannot be issued to an epileptic. So whenever you give a fitness certificate for the driving license, epileptic persons should not give. With this we will conclude today. So epilepsy is concluded. If there are any questions, we will try to answer and then conclude. Right, there are no questions, we will wind up.